So hello everyone. It's 12 o'clock Greenwich Mean Time. I'm John Damilakis and welcome to today's IMPW webinar. First, I'd like to introduce the moderator, Dr. Chai Hong Yeong. Chai works as Associate Professor at the School of Medicine, Taylor's University, Malaysia. She completed her master's degree in medical physics at the University of Malaya and her PhD in the same university. Chai was chairperson of the 18th Asia-Oceania Congress of Medical Physics, and her areas of expertise include medical imaging, radiopharmacology, and radionuclide therapy. Dr. Yeong has authored or co-authored many articles and books on these topics and has given many invited lectures in national and international scientific events. As you know, all webinars are recorded, and a recorded version of this webinar will also be available at IOMP's website very soon. And I take this opportunity to thank Professor Magdalena Stoeva for her invaluable support. So, without any delay, Chai, the floor is yours.
Thank you so much, John, for the kind introductions. And good morning, good afternoon, and good evening to everyone from around the world. We have almost 300 participants now, so very good numbers, and the numbers still increasing. And first of all, as John mentions, my name is Chai from Malaysia, and it's my pleasure today to be a moderator for these very meaningful sections. So today is the 4th day of our International Medical Physics Week. And today we have a very interesting topic. Does contact shielding improve patient safety, by our famous speaker, Associate Professor Dr. Paddy Gilligan. Let me introduce our speaker today. So Dr. Gilligan is the Chief Physicist at the Mater Private Hospital, Dublin Ireland. He is the Associate Professor at the University College Dublin since 2017. He has over 30 years of experience in diagnostic imaging. He also served on the state board for regulatory radiation protection agencies. He was the chair for the European Congress of Radiology Physics program in 2019. He was also the member of the Radiation Safety Committee of the European Society of Radiology and the Eurosafe Imaging Steering Committee. Prior to becoming president of EFOMP, he chaired the successful bid for ECMP 2022 for Dublin. He is a trustee of the Robert Boyle Foundation, and he is the current chair of the Gonad and Patient Shielding GAPS group of the experts who are in the process of producing consensus document on patient shielding. Without further ado, let's welcome Professor Dr. Paddy Gilligan, please.
Thank you very much, Chai and John. It's a wonderful honor to be here, and it's great to see the number of our participants from all over the world. And I'm very honored to set up my slide here. I'm very honored and privileged, and I think you have a great lineup, and I think you have Colin Martin tomorrow to talk about accidental exposures, and that should be exciting too. So the challenge that John and Madden and Chai have set me is to talk about does contact shielding improve patient safety? So that's the question, and hopefully at the end of this talk you will have a strong view one way or the other. I'd like to thank Peter Hiles from the British Institute of Radiology, who's also a member of the IPM in UK, and Eurados for some of the slides here today, and also all the authors, because I'm leaning heavily on the scientific literature in this regard to deal with this topic, because I'm dealing with a number of different types of shields, and so I have drawn many sources in it. So I appreciate the work that all of these people have put in. So I just want to talk about conflict of interest. As I said, I'm president of European Federation of Organization of Medical Physicists, which looks after about 9,000 physicists, of which about 2,000 are diagnostic and about 6,000 are radiotherapy physicist, and I am a diagnostic physicist, but when I speak as president of EFOMP, I'm 2/3 radiotherapy and nearly 1/3 diagnostic and other disciplines. So to just prove my allegiance to the radiotherapy cohort, I'm just going to talk about, we have a expert school next week on radiotherapy planning in MRI, and it's open to individual associate members. So when I know people from Chile all the way to Australia, to Africa, to Asia, to Europe. And tomorrow's the last day to register for that, and it's very good value. So I have no conflict of interest, but I have a picture here of my hometown, and you can see that we have there's a lead apron manufacturing facility here that makes patient contact shielding too. And this is located in, I live in a country called Ireland on the western coast of Europe, and hopefully you will be able to come next year and visit the Congress of Medical Physics 2022 next August in Dublin, and I look forward to seeing you there. So our country is a small country, and I just also want to say the views I'm expressing here are personal, and they're not representative of any group or policy, and the policy of the GAPS group will be published in the consensus document. So as I said, I'm from Ireland, which is on the west coast of Europe, and we didn't have great military success. And even though we had shields from the Bronze Age and from the Iron Age, and some of them were very beautifully aesthetic-wise, and they were used at certain stages, as evidence on this sculpture on this ancient Irish cross, which was situated in the middle of a town. By the time the 12th century came around, we dropped the shields, and we had a visitor from the larger island, which is England, beside us, and he said the Irish go to battle without armour, considering it a burden and deeming it honourable to fight without it. So we didn't have a great success with that policy, but maybe we'll have a better success with dropping the shielding in routine radiology practice. And hopefully I will be able to achieve your consensus on some of the aspects that we're presenting here today. To just put things in context, even though we're in the current, probably one of the greatest areas of scientific risk communication through the COVID pandemic, and we're all aware of the news every day and mixed messaging and the need for clarity and the balance between scaring people and living normal lives and what's appropriate and what's not. People still have a view around radiation safety, and it still makes the mainstream media. So for instance, you may be familiar with the three-eyed fish in The Simpsons, or here is an Irish actor acting in the HBO series Chernobyl, and he is using a form of gonadal shielding known as an egg basket, so people are still nervous, particularly around the genetic effects of radiation. And I'd also like it still makes news. And here's a case in Ireland from 2019 where a radiographer was struck off the register, and for a number of items came in front of the judge, but the judge particularly cited that it also found she had placed the health and safety of the mother of a child patient at risk by exposing the mother to unnecessary radiation while taking images of the child, and had failed to show any adequate understanding of the potential harm to the mother from such exposure. Now, so I just want to say that I'm going to refer back to this this judgment and the detail the judge provided later on in the talk, because it's relevant to one of the change management aspects of routine shielding in particularly pediatric radiography. So I'm going to talk about what is patient contact shielding, where it started, where it's going. I'm going to talk about the European consensus statement, which is in progress but very close to a finish. And then I'm going to take different types of shielding, and I'm really going to concentrate on probably the one that generates most discussion, which is around gonad shielding. We also looked at thyroid shielding, embryo fetal shielding in particularly around CT, again, and eye shielding and breast shielding, again, particularly around CT. And I'm going to then talk about some practical issues of using shielding, downsides and some upsides, and hopefully I'll give a balanced scientific discussion, and then I'm going to seek your views. I firmly believe in other people doing work, and I was talking to John prior to this meeting about delegation. So I'm going to delegate some of this talk to you, and I look forward to reviews. So I'm going to use the menti.com, and so if you log on to www.menti.com, and the code for today is 77296966, and this is just a primer to see is the software operating, and I'd like you to see, can you register your judgment. So where are you from? If you can select this, and I look forward to this being populated. Just check these are working, and I'm not seeing any results yet. If not, I might try another one if that's not working. It seems to have gone into some sort of a no, I'm not seeing any results, so we might try another one if that's not working. It froze. Okay, we might try a different one. Try this one. What is your profession? And this, I had done a test on this earlier, and it seemed to be working. Yes, the results unfortunately aren't coming in from this. Yes, it's not accepting votes.
Paddy, have you pressed the present? There is a button, present.
I'm not. This is
normally it is on the right corner. Up, yeah. There is a in Mentimeter there is a present button, and you need to press it. So that, but it is on the right up corner. I don't see it right now, but
it's not coming up, and it seems to have gone into some sort of a I will see, can I I'll move on with the talk, and I'll try it again later. Yes, it's not. I could. It's just I've stopped sharing for a minute, so apologies. I'll just try and I'll try and see. Can I
see it? Present.
I get the Menti and okay, and see is that working? And I'll just put that on Menti and present. Okay, so now we can share that, and okay, so that shows you where people are from. So so the majority of people attending today are from Europe, but we have good representation from other parts of the world. So apologies for that delay, and I thought that would work through the PowerPoint, but I will return. Okay, so next is what is your profession? And again, if I go to the Mentimeter software, and we try what is your profession? Okay, so are you seeing that? So the majority of people are medical physicists, and we have some radiographers and some radiologists and some others. So I will now return to the shielding presentation. Okay, so I am going to talk about patient contact shielding today, and shielding has been deployed to protect both patients and staff. And today's webinar will concentrate on those deployed to protect patients, not staff. And I've been involved in papers where we use shielding in fluoroscopy for cardiac interventional work. I will not deal with any radiotherapy aspects today, even though I know that shielding can be used successfully, say, to protect the fetus in radiotherapy treatments. I've been aware of some of my colleagues doing work like that. So prior to this talk, and I heard Madan speak on Monday, and he talked about, you know, that they had gone very far in his hospital around justification and talked about optimization and monochromatic sources. I'm going to assume that this is available to you all, which is not a given, that you have justification, we only do necessary exams, that they're optimized, that you have good quality control in places, that the majority of your technology uses automatic exposure control, where the attenuation it determines the amount of radiation arriving at the detector, which is then determines the amount of radiation input to the patient, and that your equipment meets reasonable standards, particularly around collimation and perhaps those identified in European document RP162. So I'm assuming that all of those things are in place. And sometimes signaling around shielding and the policy in shielding can be used. People say, well, you know, you're saying shielding, that this is the start of a slippery slope in removing all aspects of good radiation protection practice for the patient. But in fact, I would say that having a strong policy in shielding will allow us to concentrate on where we would get the most benefit out of these optimization procedures, rather than we're trying to downgrade or somehow downplay the risks or the need for optimization. And shielding, indeed, if you look at the hierarchy of controls, shielding is considered protective personal equipment, and you're better off more effective controls are involved in elimination, which would be justification, substitution, use of non-ionizing alternative, engineering controls, which would be around optimization, and administrative control around procedure. And then, and only then, do you look at PPE as a possible protector. And this is the PPE that we were talking about, and various departments will have these on the walls, and sometimes they're used and sometimes they're not. And sometimes they're disposable and sometimes they're not. And you know, the most common would be the King's Lynn gonad protectors. And then around the 2008, 2009, you would have seen these CT, breast and thyroid and eye shields. And I want to thank Peter Hydes for that slide. So the shielding might be inside the field of view, and so you have a greater potential for obscuring detail. You have a potential for artifacts, which are unwanted clinical, unwanted features on your image. And you have the potential to interfere with automatic exposure control. So if you place a greater attenuator in the beam, it'll actually cause the patient entrance dose to possibly increase. Outside of the field of view, we're dealing with a smaller dose because we're dealing with scattered and extrafocal radiation. And the risk benefit is even smaller, or the benefit risk is even smaller. There's still, particularly with CT and this, the potential to interfere with automatic exposure control, and there's the potential for artifacts in CT, because particularly in modern scanners with overscanning and other areas like that, they use data from outside the field of view to create the medical images required to do diagnostics. So now I'm going to take you on time travel, and I nearly did time travel earlier on because I tried to log on. I didn't realize that Greenwich Mean Time is not, it's not Greenwich Mean Time in Greenwich today. And I tried to log on a bit earlier, but maybe I was so excited to give the talk. But so I'm going to take you on a little journey through time and talk about shielding, which was introduced really early around the 1900s. Not long after the invention of X-rays in 1895. And then it was reintroduced in the 1950s, which was shortly after the tragedies in Hiroshima and Osaka, and there was a strong emphasis on radiation, particularly around genetics, and the risk of genetic harm was thought to be higher. And indeed, the entrance doses with the earlier technology were higher. But where we are now is that the individual radiation dose, particularly in projection radiography, has been reduced. In 2007, ICRP 103 downgraded the relative risk from genetic harm and hereditary harm in that to the particularly the gonads. And we also saw the potential to lower growth through the introduction of high DQE in digital technology. We demand good collimation and low tube leakage, and all of our optimization keeps this and quality assurance keeps this under control. We've also got improved training of staff with the establishment of very strong radiography colleges and radiologist colleges and great education programs just like this in medical physics, and then the potential for automatic exposure control, which I referred to earlier, to produce consistent images. So the technology has changed a lot. So we have better image quality with less radiation dose. And around 2010, I was trying to figure out what happened in 2010. Spain won the World Cup, so that kicked off the decade. They won the World Cup in soccer. But in 2010, we saw a whole number of papers coming around saying it was actually difficult to position these shields over the gonads. It was poor in males and even poorer in females. This was a difficult thing to do. I noticed there was a participant from Iran earlier. It's a paper from Karami et al., an Iranian group, and they did a literature survey, and they said, that you would get a dividend from improvement in training. Now, as part of a European group, we've looked at this aspect, and we haven't seen firm evidence that this has occurred to date, but we will look again to show that the improvement in training has delivered a dividend from the shielding. So around the last number of years, a number of papers appeared questioning the value of shielding from individual authors. And it's a very good review of this area, and actually some excellent photographs from this Cecile Joykens et al. And this is available through public access on the internet, and you can see the different types of shields. So these papers showed that there was a variability in practice, and maybe it was time to review the decision for routine use. And indeed, this is reflected, and some of the people I work in the European Consensus Group, Eurados, the dosimetry, they do surveys and they do excellent work, but they looked at the recommendations for out of field of view shielding in various countries and organizations, and they found a great heterogeneity. So there's many differences between the recommendations. Some of them didn't mention shielding, some of them said shielding is recommended, and some of them said shielding is not recommended. So one could be forgiven for scratching your head and wondering what to do. And all of this affects consistency of practice. It affects consistency of risk communication, and it leads to problems. And one of the problems it would lead to is mobility of workers who may have practice in one country and then in another country may run into professional problems. So the papers that appeared early in the 2010s fed into documents from the Dutch Radiology Society. It's a very good document, even though my Dutch is pretty basic. And this came onto the, then we had the German Radiology Society in 2018. The most famous statement probably comes from the American Association of Physicists in Medicine, and that's been widely endorsed. And that recommended the discontinuing of routine use of shielding in radiographic practices. In 2020, the BIR, the British Institute of Radiology, produced an excellent document that was consensus of the physicists, the radiologists, and the Society of Radiographers, and it contained great details. And then this was followed by the National Council of Radiation Protection in the US in 2021. And a large number of these bodies recognize that it's not enough just to make a statement about this, that you have a duty to follow up with patient and staff communication. As I said, this can be a sensitive topic and sometimes quite controversial. But what was noticed was that there was no European statement to date. And even though the European bodies involved in radiological provision work very well together and they have large consensus, and this is evident at the European Congress of Radiology and physics meetings, there was no European statement to date, so there was a gap. Here we see a graphical representation of some of these statements, which are worth a look at. And so we took all of these statements, and then we met and we appointed experts from a number of representing a number of bodies from radiographers, physicists, those involved in dental radiology, pediatric radiology, radiologists. And we said, let's produce a consensus document on a number of types of shields similar to those covered in the British Institute of Radiology. And we used the European template that I show you there for writing criteria. The purpose of our statement was to build on what had already been done and not reinvent the wheel, because there have been significant literature searches and in the documents that are referred to in the previous slides. The idea of communicating consensus is to communicate general agreements. We wanted something that was clear to use. So there's over 200 languages in Europe, and it needs to be intelligible to all of those people. And subtle changes in languages, as we know, can cause cultural difference that can cause some of the anxieties and conflicts between people. So we also made, the purpose of, well, why I'm a medical physicist is really to benefit patients and hopefully benefit staff, but really that we also have to make sure a patient representative was involved, and we're lucky to have Eric Briers on our group. We also need to recognize that this may represent change management for some, and with any change management, particularly around practice and culture, that you really need to think about what you're doing, make a consensus and make it clear. We also need to realize that this can be a sensitive topic, and so some of these debates become quite strong. And also, this is just a European view. So what is true for Europe, technology, culture, training, professional wise, may not be true for the rest of the world. So, we're not advocating that our views somehow should dominate that of the IAEA or dominate that of the ICRP, but rather should feed into it. And here we see the groups that contributed to experts for the GAPS group. And we hope to publish the statement, which is very close to completion. We just need a mechanism to publish it in a number of journals, from the radiographers, from the physicists, from the radiologists at the same time, so that it would give a single voice to avoid some of this interprofessional contribution, because sometimes in change management, people can feel that their own profession's value is being degraded because they may or may not agree with the findings of this consensus. And here, this is the team I have been privileged to work with, and you will know some of them from even earlier in this talk or from any involvement. So I would just, it's been a privilege to work with you. It's great. It's been very enjoyable. So I just want to talk about how we communicated this. We used 3 levels of recommendation, and sometimes that is difficult too, because particularly when you want to deal with many exceptions that you might have in clinical practice. So the green shield is that you should use shielding in all cases. The may use that in some circumstances, the general agreement favors usefulness. And we have also one saying that we've not recommended to shielding, so the evidence or general agreement is not to use patient contact shielding. We also needed to cater for the colorblind among us by using a symbol that was easy to see in terms of visually, also for those who copy things in black and white. So first to look at the different types of shields covered by the document, and I said I'll deal with gonadal shielding the most, and we can see the difference in radiation dose from the 1900s, where the dose was very big, of the order of over 100 milligray down to 2 to 3 milligray, and this is for an AP pelvis radiograph, and I have borrowed that from the British Institute of Radiology. And there's another slide that Peter Hawes gave me showing that although the doses have reduced and the amount scattered outside the field of view has reduced, the tube housing leakage has reduced, and this is part of your acceptance testing, and the scatter. So our doses have reduced, the fraction scattered outside the field of view has reduced. So that's good news. So that lowers the risk to organs outside the field of view. And also the actual relative risk itself. So in terms of the tissue weighting factors recommended by the International Commission of Radiation Protection, that these have decreased by a factor of 3 since the 1970s, whereas the breast cancer risk has increased during that period and has gone down and back up again. I also think it's very important that you acknowledge that if there's a change in risk perception or new risk perception or new information, that you have to be able to change your ability during that time to review it. And here we can see the emphasis is greater on carcinogenesis, and the genetic information has gone down. The lifetime risk of cancer incidence for females by organ and age was presented by the Health Protection Agency in the UK in 2011. And we can see that what we say for one period of time in our lives may not be appropriate for another period of time. So for instance, the young female breast is more radiation sensitive and than, say, the lungs for younger females. But then as we move through life, the lungs become more sensitive. So shielding one organ and using the same philosophy throughout our whole life doesn't provide benefits either in that regard. Likewise, with the thyroid, we have evidence of the thyroid in a younger cohort, and this is 35 years since the Chernobyl accident, and they found an increased thyroid cancer rate among children. So there's a genuine risk there, you know, below a particular age. And for instance, in Ireland, the thyroid shielding for dentists is recommended with circular collimation below the age of 30. So what's true for one age group is not true for another age group. And also, if we are concentrating on the gonads, then maybe we're not putting as much emphasis to where the action is. So our argument would be that the gonads is where the action isn't, and the rest of the body from here to here is where the potential cancer risk is. And that's where we should concentrate our optimization and dose reduction efforts. And use of shielding is not without risks, although it can be shown in certain cases to reduce the dose. You can obscure certain features, and in the radiograph here you may not be able to see, it's too small, but there's an osteomyelitic lesion that's covered by the gonad shield, and all that to protect a very small risk. So the risks, you know, start at highest at 1 by 10 to the minus 6 and go right down to 0.1 by 10 to the minus 6. So that's 1 by 10 to the minus 7. So the risk of lightning striking is 1 in a million. We know that it's the same as a chest x-ray. So we're protecting against a very, very small risk. And it's very interesting to think about risk communication and these relative risks and what's known as the Kalman scale of risk perception in the current time around the pandemics. And if we look at the AstraZeneca clots, that the risks are also of the order of 1 in a million and those. So, you know, it's a very, very interesting analogies. So we can see a very small risk, potential to obscure clinical details, and also that leads to the potential for retakes. And that paper by Franson in 2012 again, is, you know, indicates some of the problems with using shielding against a small benefit. And here we see a paper from Fawcett, who's quoted in many of these documents on shielding, showing that the positioning of gonad shields in females, which is represented by the blue, and males, which is represented by the purple, the use of shielding, that it's very poor in females, and the location, and it's also difficult in males due to maybe undescended testes or hernias, or females that other papers have shown why this, and you'll often see this diagram from Featherstone and this was reproduced in Thomas Warlow's studies, showing that the placement that shielding is difficult to do, and it's an ultrasound, you know, a location of the ovaries, and even when it's done, it's not done consistently, and when it is done, the actual location of the ovaries is difficult. So we have a difficult task to reduce a small amount of radiation with little risk and that has potential downsides. And if we misplace, this is a paper produced last September, and if we misplace the shields, the benefit goes down rapidly within a couple of centimeters, depending on the level of filtration. And if we do place the shields over the automatic exposure control, this can actually lead to an increased dose, as showing this paper by Kaplan in December of last year. So these are all new and further evidence about some of the difficulties associated with shielding. And it's not difficult to understand why radiology or radiography educators would end up with different views about whether shielding is appropriate or not, and the benefit it brings. And again, such a disparity of extreme views would show you why we would have inconsistencies, and this is not good for the patient experience. And that's why we're trying to achieve consensus and give clarity and leadership in this area. In CT scanning, this paper by Yu et al. Is a very good paper, showing that in the pediatric chest CT, that once we move out a particular distance, there's very little difference between the benefit the lead apron provides in terms of actual radiation dose reduction. And one paper that comes up consistently in people who are really in favor of maintaining shielding, they always point, and quite rightly, to this paper by Christian Hole from 2005, where he showed that he was able to get about a 3-fold reduction from 2 milligray down to 0.09 milligray sorry, 2.4 milligray down to 0.3 milligray in radiation dose tested by placing a TLD on the scrotum and using the capsular shield that I showed you previously. And I'm not sure if that shield is widely available anymore. And again, this depends on the technology, and he used his patient cohort were adult males of a particular age. And one thing, I remember I showed the difference in radiation effectiveness over life. The imaging population, the majority of patients are in the latter stages of, the older patient cohort. So his group of 61-year-old males would reflect that. And again, the risks in this group would be considered to be smaller. Lawrence Dower didn't manage to get the same level of dose reduction in his, and even though in relative terms these dose reductions look good in terms of 80%, the actual risk and radiation dose benefits are small. And so our European group, it looks like we're not going to recommend male and female gonad contact shielding. And I am going to see, can I present this study, and I'll try you on another so the question I have is, do you agree with shielding? So the majority of people agree that shielding inside and outside the field of view is not recommended, but there's 4 that disagree, 7 that do not know, and the 5 that disagree are going to continue with the outside field of view, and some of them. So we've got a changing set of opinions. The majority, and remember, consensus is around general agreement, and there will always be a range of views, and I think we have an obligation as scientists to listen to these views and present our arguments, because ultimately this will affect how our radiologists, radiology departments are run, and the view of the patients. So thank you very much for that. It's great to see that we have a range of views, and I'm going to try and go back now to the PowerPoint presentation. And okay, so now we also looked at thyroid shielding, and as I said earlier, that if you have good rectangular collimation in dental, you will get a good dose reduction, and the primary beam shouldn't go anywhere near the dental, or shouldn't go anywhere near the thyroid for the majority examination. But if you've big, wide circular collimation that we still come across, you may end up irradiating the thyroid. And that'll give you some of the rationale. So the thyroid shield is one area where we recommend it in certain dental examinations to stick with the shielding. And so for capillectric radiography, we say you could do it inside the field of view, provided you're not obscuring clinical details or the automatic exposure control isn't present. And likewise for thyroid shielding, for dental x-ray, where you've got large circular collimation. And although you shouldn't come across, this is one I tested 2 years ago with a 7-centimeter collimator. You can see it striking the fluorescent screen, and in that case, it would be maybe appropriate to use thyroid shielding. Also, Ruben Pavels, who's a member of the group, did significant work showing that in cone beam CT for pediatric, you get a genuine benefit from the use of thyroid shielding in that case. But again, technology and those test cone beam CTs, there's lots of different types of technology, and some of them now start to feature some sort of automatic exposure control. So this may change. So in these cases, you would really want to consult your medical physics expert and those experts around how to use the machine and get the best out of the machine. So I have asked, do you agree with the statement on thyroid shielding, and I will see, can I do that? And so on thyroid shielding, we have a good agreement, but some people don't agree with that statement on thyroid shielding, and some people aren't sure. Okay, so we have a range of views, but general consensus is that we have good agreement on thyroid shielding. So I will go back to the PowerPoint presentation, and thank you very much for giving your views here. So the next area, and again, this is a very sensitive cohort. We're dealing with the fetus, and in pregnant females, the risk of clots and pulmonary embolus are quite high, and we use the most common technique for detecting pulmonary embolus in the pregnant female is CTPA. CT pulmonary angiography, and work done by eyeball has shown that because the majority of the scatter comes internally, there's very little benefit to shielding externally, and that the absolute risk to the fetus is less than half the occupational dose limit in Europe from that scan, and we would have a very strong benefit if it's indicated and you've done your D-dimer workup and elsewhere. And a Swedish group by Dino Pagano did some work to showing that actually the shielding, due to interference with the automatic exposure control, would actually increase the would increase the dose to both the mother and to the fetus, and that by shortening the length of the CTPA, that you could reduce the dose significantly down to a very insignificant level. And again, this is from May of last year, and you see the absolute figures here. Shielding can be uncomfortable for patients, and another study by eyeball showed that 30% of patients, 30% of radiographers had experienced patients who are complaining about the weight of the shielding, and also the staff found the shields very heavy. So a typical lead apron is about 4 to 7 kilograms. So, maybe the skirt is about, 3 or 4 kilograms. That's with sort of modern aprons, and some of them might be even heavier. And I imagine that the manipulation is quite hard. So you may have a manual handling risk associated with the use of these shields. So for these reasons, and the potential for artifacts and the potential for interfere with the automatic exposure control, our group has not recommended the use of fetal shielding. There may be cases where the patient's very anxious, and you have to consider that and won't go ahead with the scan unless the shielding is present. And I think in those cases, you know, you will rely on the professional autonomy of the individual, but they will be, you would hope, exceptional, and you would have a good chance to communicate with the patient beforehand. So I will, we will do another survey. So if you can log on there, and I'll hopefully change on to the next back to Mentimeter. And so the majority of our participants believe this, that they do agree with the statement of fetal embryo shielding, but we still have a good 13% or so that are not in favor, another 13% that aren't sure. So, you know, there's lots of complex physics, and it actually depends on the technology available. So, you know, I'm presenting this in a very whirlwind manner, given the time that is allowed to me. So I just, we'll move on then back to the PowerPoint, and I'll just thank you for your help on that. And another aspect we dealt with, and you'll know one of the great authors on this is eye shielding in CT. And you can see that John Damalakis' group had a paper on this showing the artifacts in the eye and methods of remediation. And I haven't seen the use of this widespread, but the paper of Poon and Badawi show, and they would recommend that tilting the CT gantry actually produces a greater benefit, and shielding should be not considered unless the tilting wasn't available, and this would, you know, remove the need for, you know, mitigation of the artifacts or any potential interfering with dose modulation systems. So again, in eye lens contact shielding, we have said that we would not recommend the shielding in these cases. And I will ask you again, we'll go into the Mentimeter, and I'm curious to seek your views on that. Let's see what we come up with here. And again, we're dealing with, you know, a significant percentage in favor, but we have some people not sure, and then we have 5 definite no. So we have a range of views there, but the majority would agree with the output on of the GAPS group in that area. Just in terms of breast shielding, one of our group, Shane Foley, and a group from the university that I work in, they produced a paper showing that looking at displacement and breast shielding, and they found that for different breast sizes that they had different effectiveness of shielding, and for the large and small breasts that actually the shielding gave a higher dose. And again, this is based on, although it's ECG tube current modulated, it isn't, you know, it doesn't have automatic modulation based on the topogram, and placing on and off shields could have the potential to interfere with that. And I don't think they saw many artifacts in that, but this could have the potential to deal with artifacts. This is looking at cardiac CT. So for these reasons, we would not recommend breast contact shielding. There's another interesting paper, and I just put this in because I think this is the future of dosimetry, where we're looking at the foci of chromosome aberrations, and they did not see a significant difference between the breast shields and no breast shields. One thing about lead light shields is that they contain materials that, particularly at low kV, can cause fluorescence, and there's some work done by the groups in Munich around the effect of this on leukocytes, and we may get different results if we use LED light in some of these areas, so just to be aware of that. So for breast contact shielding, we again recommended that this is not used, so we said this is not recommended. And again, I will go to my survey, and we will see Mentimeter. So I have to look for a refund on my plugin. So we'll look at the we don't. We have the fetal, we have the eye. Here's the breast shielding, and so the majority again, and it seems like we've a 5% who are in favour of shielding in all of the statements that I've had, and we've some not sure's, and the majority are in favour of the recommendation of discontinuing the routine use of breast shielding. So I will go back to this, and I have to keep an eye on the time. So it finally works at the end. So just further practical implications of shields. So we talked about the weight for the patient, infection control, and there's a paper by Balter on lead aprons. The procedure time. So if you're doing 40 to 50 CT scans a day, and you take 2 or 3 minutes to do the put on and off the shield, that can end up in 4 or 5 patient slots. And if you have shields, you have to do quality assurance on them, acceptance test them, and they have to make sure they're stored properly. And then there's the cost of each, which could be up to €100 or so, and the environmental issues. There may be cultural issues around some of the placement of breast shields and the clamshell shields that I showed you earlier. And then there's the risk of inconsistent practice in causing anxiety among patients. Just in terms of the infection risk, this is a paper from 2019, and they looked at the bugs on theatre lead aprons. And I know they're not equivalent to patient contact shielding, but they showed that when they cleaned it with an alcohol wipe, they could reduce the number of long-living nasty bugs down to a smaller number, and then these grew again a couple of hours later. But if you look at, they used an alcohol-based disinfectant wipe. If you look at the Mavic website, their leading manufacturer lead aprons, they don't recommend the use of alcohol-based. They don't recommend the use of alcohol-based disinfectants, and said it can damage the radiation protection material. So the challenges, I referred to this at the start, and I'm coming near the end of the talk now, is that a pediatric patient not wearing shielding, but the parent asked to wear their lead apron. That was the court case that we heard at the start. I think this is one of the difficulties. I have personal views that I'll reveal when we do a survey in a second. With any radiation risk information, particularly at low levels, we have uncertainty and risk, and new information comes to the light the whole time. And there's a paper in PLOS in 2020 talking about, from NEED, a group in Philadelphia, talking about an association between lower abdominal pelvic radiation and testicular cell tumor risk. And even though the symmetry was poor and they sort of linked bariums and CTs together, and the numbers were small. Nonetheless, you need to keep looking at these papers, and we're looking to have some radio biological input into our group to look at these. So these are something you need to keep in light, and why it's important to have a review. We have to talk about the patient autonomy. What if the patient absolutely demands a shield, isn't willing to put up the risks of artifacts and obscuration of details? Do you go ahead? You professional autonomy. You don't want hierarchical model, and you want to encourage people to innovate and self-think. And many of the earlier papers talked about the potential for training, and the strong beliefs out there that training could overcome some of the difficulties, particularly in the misplacement of shields, and that's something that needs to be looked at. And again, I just keep on talking about inconsistency, and that is not something that we want in radiological practice. We need to harmonise them in the benefits for the patient. And then we've got to think of the high dose and cumulative patients And I heard Madan referring to that at the start of the weekend. There's a number of papers on this. Certain patients are now going to start to experience tissue effects. Particularly in interventional radiology, we may get cataract damage to the eyes, and that may be some area where shielding may be of benefit, providing it doesn't up the dose elsewhere. And again, these are areas that will need to be revisited, particularly as more information is coming out about these multiple exposure and high cumulative dose patients. So I just want to do two last surveys, and then I'm just going to try if you so the next survey is if the patient is asked to if the patient is asked to, would you ask the parent care of a child to wear a lead apron, even though you said shielding is necessary for the child? The majority of people would say yes, and my personal view would be yes, because the person holding the the parent in the room does not, carry many of the risks around interference with the automatic exposure control or obscuration of details that the patient would get, even though I think it is challenging to explain that. So I will return now to the so just if in the case that you do have to use shield, the document also alludes to training that will be need to given around some of the areas that dealt with the selection of appropriate techniques, communication skills to the patients, and how to clean and disinfect shielding, and particularly around how to communicate benefit risk. And also, it's not just risk of radiation, but there are risks associated with using the shields, and they have to be also communicated to the patients in any benefit risk paradigm. So to conclude, in my personal view, patient shielding is of limited value and risk reduction in routine clinical practice of current radiological technology. There are downsides in using shielding, that it can obscure pathology, you can cause artifacts, you have interference potential with automatic exposure control, you've got practical issues around weight, workflow, and infection. So there's a growing consensus that its use should be discontinued, routine use should be discontinued. But challenges remain in change management due to technology, autonomy, risk perception, and also that the landscape may change all of the time. So you need to review these recommendations regularly. And these are the summary page that is going to be published, we hope, with the consensus document. So we're only recommending may do this in 2 cases. So now I present the final survey, and the postscript is, what's your view? Does contact shielding improve patient safety? And I'd be curious to know your views on that. And we'll do one last and I'm curious to know how it's referenced at the start of the talk. So the majority of people don't agree with the motion that contact shielding does improve patient shielding, and that feel that contact shielding does not improve patient safety is the majority view. So does contact shielding improve patient safety? The majority answer is no. There's a significant 25% who believe it does, and there's 15% who believe that it's, or are just around that, who believe that it's, they're not sure. Sorry, they're absolute numbers and not percentage numbers. So with that, I'll just return to the presentation again. And thanks for your patience on this. And I just want to get a chance to, if you get a chance, could you please, I would recommend logging on for our wonderful European Congress of Medical Physics. We have, it's going to be a very exciting lineup in June, and I hope you can attend. It's a shame we couldn't have it face-to-face in Torino, but if you log on to www.ecmp2020.org. So I just want to thank you very much, and I don't know if we have a lot of time for questions, but Thank you for bearing with, particularly for your patience around the use of the survey polls. Thank you.
Thank you so much for the very informative talk, and thank you for making it. We have 1 minute now. Questions. Yeah, if you don't mind, I will share my screen on the questions that we collected. So the first question actually is the last questions that I received, when do you plan to publish the consensus document?
Well, I would hope that we would have it. We'd actually hope to have it for March of this year, but we hope we will have it in the next few months. But as I said, we're trying to publish it in all of the different journals simultaneously, and that creates problems because we've got Elsevier, we've got you know, the other publishers. So the next thing we're doing is we're just doing some final tweaks to the document, and then we're getting board approval from the various bodies. And I would hope by you know, the end of this year or by the autumn that we would have this document published. I think there's broad support for our consensus view.
Thank you so much. Another question, not sure about a single patient representative in a consensus document. Suggest seeking input from multiple patients or patient organizations.
Yeah, patient representation is always very hard to achieve, and actually to find patients, and there's ethical considerations about, you know, if I'm during working time attending a meeting on radiation safety, and the only person not being paid, you know, I do lots of volunteering work, the only person not being paid is the patient in the room. It's quite hard to get patients and patients' body. We definitely would like to see more involvement, but the patient representative we have is the representative from the patient advisory group of the European Society of Radiology. So it's not just really, you know, although there's one person, you know, that they would have access to a broader group. And actually all of the people in the, you know, our relatives, the patients, our parents, or, you know, so, yeah, I do, you know, I think the issue of patient consensus is challenging. Yes, we've tried to address it. Of course, we'd love more patient involvement. Yeah.
Okay, thank you. Second question, this is like a comment. Thyroid shielding should be recommended for interventional radiology with fluoroscopy.
I'm not sure about that. I've never really seen thyroid shielding used to good effect, and we didn't come across any papers in interventional radiology. And if there is some, I'd be glad if the person who made that would share them with us. You know, yes, if there's potential to interfere with the automatic exposure control, and then, you know, that is generally not a good idea. There's the potential for artifacts, and then we've some of the infection issues, particularly around you know, using that. So yeah, if there is evidence out there, I'd like to see it, but I haven't seen it to date, and I haven't seen it mentioned in any of the documents. That doesn't mean it's not there.
Thank you. At what point does the inability to apply the shielding properly mean that it just goes over the line of practical in our use of ALARP?
ALARP is maybe a UK concept as it allows reasonably practicable. Yeah, like, yeah, instead there's, you know, logistical, it's all about benefit risk in my view, and some of the risks associated, and some of the things some of the penalties from using shielding, you know, they do outweigh, you know, the very small dividend you might get in risk reduction. So, and I, you know, definitely, you know, even with the best will in the world in getting the ideal shield, we can see the benefits, particularly in gonad shielding, is small. And then, so, you know, but the practical aspects even make that dividend even harder to realize. So the answer is, I think that if it's very difficult to do with very little dividend, that the loss from doing it is outweighs, would mean that you wouldn't recommend it.
Yeah. John, do we have time for another, maybe 2 more questions?
Well, for one more question, yeah.
Okay, maybe one last one. All right, maybe you choose, Paddy. There are 3 questions here.
Well, we've done the why won't you address superficial radiotherapies? Yeah, we didn't deal with the group of experts that we've brought together are mainly from the diagnostic imaging world through the European Society of Radiology. And yes, I think, you know, there is a potential for another group in radiotherapy, but the expertise isn't there in our group at the moment. But we could, you know, help them with some of the learned experiences from developing the consensus statement and the need to bring the disciplines together. Yeah, and the national authorities, I think, have dealt with that. There's major inconsistencies, and hopefully documents like that we're trying to produce will bring some sort of an end to that, because it's not fair on patients and staff.
Yeah, thank you so much, Paddy. It's a very informative presentations and excellent presentations from the comments from the participants. Lastly, thank you again, Paddy, and all the audience for your participations, as well as your comments and questions, and look forward to the consensus document, Paddy, in March next year.
Thank you very much, Chai and John and Matt, and you've been very helpful to me today, particularly some of my difficulties around my Menti thing. So thanks. It's been a great opportunity, and I look forward to it. It's been a wonderful privilege to be part of this week. And so yeah, thank you again.
Thank you, Paddy, for your excellent interactive talk. Thank you, Chai, for your skillful moderation, and all of our participants for active participation. Tomorrow, another hot topic, how to manage accidental exposures, from a great speaker, Dr. Colin Martin. So see you tomorrow. Bye.
Bye, everyone. Thank you very much.
Bye.